Anil. Good morning and welcome to today's seminar on approach to nystagmus. My moderator is Dr. Soumya Madam. The contents of this presentation will be in the format of introduction, classification of nystagmus, approach to nystagmus, followed by a summary. So coming to introduction, nystagmus is derived from the Greek words nystagmus and nystazein, which mean inevitably and is an involuntary, rapid, rhythmic, oscillatory movement of the eyes with at least one slow phase. It has been grossly divided into pendular nystagmus and jerky nystagmus based on the number of slow phases. When it has both of the slow phases, it is called pendular nystagmus, and if there is one slow phase, it is called jerky nystagmus. In this example, even though it is difficult, but it is a pendular nystagmus with both sides slow phases. However, as opposed to that, in the second example, there is a jerky component to it and only one slow phase. So that is a jerky nystagmus. So how nystagmus is different from saccadic intrusions? So we have to define these moments by the initial phase. So if the initial phase is a slow phase, it is called a nystagmus. And if the initial phase is a fast phase, it is called saccadic intrusion. Saccadic intrusions are the closest differential to nystagmus. And although nystagmus is often described by the direction of its quick phase, that is the fast phase, it is the slow phase that is the underlying pathology or the disorder. Coming to classification of nystagmus, it is pathophysiologically divided into physiological, infantile, and acquired nystagmus. So it is the failure to stabilize eye position on target when the saccadic system tries to oppose it by redirecting the eye towards the target. So in physiological as well as infantile, in physiological nystagmus, it is usually seen in normal individuals. However, in infantile nystagmus, it is seen from birth or after a few months of birth. And acquired nystagmus is pathological often. So I'll be taking a pathophysiological approach to diagnosis of nystagmus, and mechanisms that prevent deviation of eye from target is usually involved. So the most common mechanisms include the vestibulo-ocular reflex, the gaze holding mechanism, and visual fixation. Coming to the first mechanism, which is the vestibulo-ocular dysfunction or VOR dysfunction, based on which it is divided into peripheral or central vestibular nystagmus, and central is again has many subtypes. Afferent from the right labyrinth via the vestibular nerve, which ascends to the vestibular nucleus of the right side and crosses over and supplies the sixth cranial nerve of the left side. And from there, via the MLF, it reaches the right medial rectus nucleus. And so in case of a right labyrinth activation, the normal response would be the movement of the eye towards the left side, that is a left eye abduction and right eye adduction based on this. However, in case of pathology that is involving the right vestibule, such a by a rapid saccadic movement towards the same side, that is towards the side of the lesion. So no. Yes, ma'am. Sorry, the rapid saccadic movement is towards the opposite side. Sorry. Yes, I'll come to that, ma'am. So normally in a rest, there is a resting tonic firing. Yes, ma'am. Yes, it is in the same. So when the right labyrinth is not fired, the left labyrinth takes over. There is excessive firing from the left labyrinth, and that pushes the. So there is side takes over and pushes the eye towards the same side as the lesion. So opposite side takes over the eyes to the side of the lesion, and there is a rapid quick phase of saccade towards the healthy ear. So that is the point behind this. So in this video, however, what we were seeing is when the right labyrinth vestibule is involved, the left vestibule takes over and pushes the eye towards the right side, that is the lesional side, and the saccade is towards the left side, that is the opposite side of the lesion. So this is what I was explaining. From both the ears, there is tonic firing at the resting state. And when there is hypofunction of one ear, in this case, the left ear, the right side takes over and pushes the eye in a slow drift towards the left side, that is the lesional side. And the saccadic intrusion, the saccadic corrective saccade will push the eye towards the healthy ear. So it is away from the side of the lesion. So a peripheral vestibular lesion causes nystagmus to opposite side. Now some characteristics about this peripheral vestibular nystagmus. It is mostly mixed horizontal and torsional in trajectory, and it usually beats away from the side of the lesion in cases of acute lesion. And it shows a linear, that is constant velocity as seen in this eye movement waveform. There is constant velocity that will appear like sawtooth-like pattern. And nystagmus increases when the eyes are turned in the direction of the quick phases. This is the Alexander's law. And this nystagmus is suppressed by visual fixation and increased when the fixation is removed. Increased or precipitated by certain changes like head position change or vigorous head shaking and certain other maneuvers like hyperventilation, etc. Saccades and smooth pursuit are relatively preserved as this is not the circuit that is involved. As I was saying, so in this patient, there is a left gaze evoked nystagmus. Sorry, left vestibular nystagmus. There is a fast component towards the left, and the amplitude appears to be more when the eyes were in the left gaze. However, as the patient is moving towards the right, there is the eyes are still beating towards the left side when the eyes were positioned in the right gaze as well. However, the in the right side. Take the video again. In the left side, the amplitude appears to be higher, and in center, a little bit lower. And towards the right, it's the least. So that is the Alexander's law. The intensity of the amplitude of the nystagmus is greater in the side of the quick phase. So it is mostly unidirectional. It is unidirectional. So peripheral vestibular nystagmus is unidirectional. Some causes of the peripheral vestibular nystagmus are benign paroxysmal positional vertigo, labyrinthitis or vestibulitis, Meniere's disease, and vestibular schwannoma. The most common condition is BPPV, that is benign paroxysmal positional vertigo. It's a usual condition that presents with brief vertigo of less than 30 seconds and usually induced by changes in head position as well as rolling over, that is bringing the head towards the shoulder or bending down or looking up. And it is usually caused by, the cause is unknown, that is idiopathic, and can be caused by head trauma or infection. The most common type of BPPV is the posterior semicircular canal BPPV. So in this video, we can see that there is this membrane called otoconia membrane, from which otolith membrane, from which the otoconia debris that is usually absorbed is persisting and is pathologically entering the endolymph of the posterior canal. So there are three canals, and it is entering the posterior canal. So when there is movement of the head, this debris will cause disturbance in the endolymph and can cause abnormal firing from the vestibule. However, there is another mechanism. The mechanism that I had described now is called canalithiasis. However, there is another mechanism called cupulolithiasis, where the otoconal debris that I had mentioned has been adhering to the cupula of the affected semicircular canal, which is a structure already present in the ampulla crista of semicircular canal, where these debris go and attach to it and cause abnormal firing. The inevitable consequence of this is abnormal stimulation of the vestibular apparatus, and that will cause abnormal stimulation of the vestibulocochlear nerve. This is the way to test posterior semicircular canal VPPV, where the patient is rapidly made to place in a direction where the head is turned towards 45-degree towards one side, and there is a pillow placed under the trunk to keep such a 30-degree bend at the trunk. So that will cause, after a latency, that will cause a torsional vertical nystagmus, like in this video. When the patient was turned to the right side, the patient developed a latent nystagmus after some time. And towards the left side, if she's placed, and after around waiting for some few seconds, there is no nystagmus when the eyes were placed towards the left side. So this maneuver is positive for right side. So, however, in this video, we can also see that in the first time, the nystagmus was higher in amplitude or much more intense. However, again, when the maneuver was repeated to the right side after doing it in the left side, the intensity of the nystagmus had reduced. So there is a fatigability that was demonstrable in cases of peripheral cause of vestibular nystagmus. However, that is not the case with central cause of vestibular nystagmus. We would not find a fatigability. And other features that are different between the peripheral and central vestibular nystagmus is the duration. Peripheral vestibular nystagmus usually will last less than 1 minute, and it will be more than 1 minute in central vestibular nystagmus. And there is a latency that is present with peripheral vestibular nystagmus. However, that is not seen with central vestibular nystagmus. Coming to central causes of vestibular nystagmus, when do we suspect central causes of vestibular nystagmus? When the nystagmus is purely vertical or torsional, or when the positional nystagmus is not compatible with that of autolithiasis, as we had seen before, there is a gaze-evoked nystagmus, or there is no suppression with visual fixation. So a disturbance within central vestibular structures can lead on to an imbalance of central vestibular tone, and that will cause a central vestibular nystagmus. As in this case, when the patient is looking towards the right, in right case, there is right beating nystagmus. In the center as well, there is a left beating nystagmus. The quick face is towards the left. Center as well, we can see that it is left beating and primary position. And in towards the left as well, it was Again, in this video, in the right case, there's the fast face is towards the right. And as the patient positions the eye in the primary position or in the center, the fast face is towards the left. There is a rebound that is called a rebound phenomenon where there is a reversal in the central, the primary position as well. So how do we differentiate between peripheral versus central vestibular nystagmus? So peripheral vestibular nystagmus is usually horizontal, or it usually has a horizontal with torsional component. However, central vestibular nystagmus could be purely vertical, torsional, or horizontal, or usually could be mixed as well. Peripheral vestibular nystagmus is unilateral without any reversal in direction. However, central is bidirectional and direction changing. Peripheral vestibular nystagmus is only jerk nystagmus. However, central could be jerk or pendular nystagmus. Patient usually complains of positional vertigo in case of peripheral vestibular nystagmus. And any causes of central vestibular nystagmus can always mimic peripheral vestibular nystagmus and has to be differentiated. So when we do this maneuver called head impulse test, towards the left, both images towards the left show us a normal VOR reflex. That is when the eyes are able to fixate at primary position, and when the head is moved towards the left in this image, is still able to fixate at the visual target because of the VOR towards the right. So, however, in case of vestibular loss in the left side, the patient is able to fixate in primary position. Or when the when the head is moved towards the left, the patient is unable to view on the target because of loss of. There is a corrective circuit to compensate towards the right side. So the compensatory circuit is towards the right side. In this video, the head is moved slowly towards the left and rapidly towards the right, and now in the opposite direction. And at that time, we were able to see a corrective circuit. Now, again, towards the left, when the head is moved, there is a corrective circuit towards the right that was seen. So a left vestibular component, vestibular dysfunction is the likely cause. And that this won't be seen in central causes. So that differentiates it from peripheral vestibular nystagmus. Coming to another type is head shaking nystagmus. So there is when the head is shaken horizontally at the rate of 2 to 3 hertz for around 10 to 20 seconds, it can induce a horizontal nystagmus based on this law called Evol's second law, which is based on non-linearity. So in the inner ear semicircular canal, excitation causes a stronger response than inhibition. So excitation is much more than inhibition. Firing will be much more than inhibition. So in a healthy system, rapid shaking should negate the firing from both the ears, the excitation from both the ears. However, when one ear has a unilateral deficit, that is one ear is hypofunctioning, the normal ear produces a stronger excitatory signal than the damaged ear and causes rapid during the rapid head oscillations and cause the horizontal nystagmus towards the same side. So there is asymmetrical input that is accumulated, and this accumulation causes a bias, basically. So in this case, let's say if it was a unilateral deficit of the right side, that asymmetrical input, that is excitatory input, is accumulated in the brain's certain center called velocity storage mechanism, which is within the vestibular nuclei. And when the head is stopped when the head is shaken and stopped, this accumulated bias is suddenly released, and it will cause a transient nystagmus with a slow phase, that is pathological phase directed towards the side of the lesion, and fast phase, which is a corrective circuit, away from the side of the lesion towards the intact site. So this is also based on VOR. In this patient with acute left lateral medullary infarct, after head shaking, this is head shaking now. there is a left beating nystagmus even at the primary position. That is because of the ipsilateral lateral medullary infarct. Coming to another type, that is downbeat nystagmus. Downbeat nystagmus is the most common of the central vestibular nystagmus, and its jerk nystagmus waveform begins with an upward. There is a downbeat, however, the slow phase will be towards upwards, and corrective saccade will be downwards. And it is best evoked on looking down and laterally, and is often in association with another horizontal gaze evoked nystagmus, and hence can appear as an oblique nystagmus on lateral gaze. The slow phases can have linear increasing or decreasing velocity waveforms, and it is poorly suppressed by fixation as opposed to peripheral vestibular nystagmus, and as well can be precipitated by maneuvers like altering head position, vigorous shaking, etc. And convergence can have a variable effect on downbeat nystagmus, can increase, suppress, or convert it to an upcase nystagmus, upbeat nystagmus, and it is associated with other signs of vestibulocerebellar involvement. So and this is the pathophysiology behind this. So towards the left is a normal circuit where from the flocculus there is an inhibitory afferent that is going towards the superior vestibular nucleus. And that in turn is excitatory to the superior rectus muscle via the ventral tegmental tract, which is a prominent tract in the extending from pons to midbrain. And that will in turn excite the superior rectus, and which will cause the eyes to move upwards. Apart from that, another afferent is going to the caudal medulla, where it excites the caudal medulla. However, this caudal medulla sends a negative feedback loop to the flocculus. So in normal condition as well, there is an upward velocity bias that is seen. Usually, the eyes drift upwards based on this circuit alone, and there are various other compensatory mechanisms to stop that as well. Whereas in case of downbeat nystagmus due to a floccular lesion, this inhibitory supply to the superior vestibular nucleus is lost. So that will cause overexcitation of this superior rectus via ventral tegmental tract, and that will cause abnormal slow phase, increased slow phase towards upcase, and a corrective saccade towards the opposite side, that is downbeat nystagmus. The other mechanism is uh, via the Purkinje cells in the vestibulum will be normally sending inhibitory, as I had mentioned earlier. However, there is an asymmetry. They will be sending more inhibitory fibers to the anterior semicircular canal. And inhibitory projections will not be significantly to the connections of posterior semicircular canal. Such an asymmetry exists. And when a lesion in the vestibulocerebellum is specifically lost, there is much more that inhibitory signals to the anterior semicircular canal will be much more lost, and causes a tonic unbalanced excitatory signal, which is leading to upward slow drift of the eye. When the anterior semicircular canal inhibitory signals are lost, it will be excited, and that will cause upward drift and a saccadic downward, a down gaze saccade. There are various other mechanisms also mentioned in literature, including the involvement of paramedian brainstem lesion, where there is a neurons in the paramedian tract, where that causes when that is lost, that will cause decreased stimulation of the flocculus, and whereby will be inhibiting, there will be decreased inhibition of the superior vestibular canal, and that will cause in turn of increased superior rectal stimulation. So the various causes of downbeat nystagmus. However, the most important ones are cerebellar degeneration and craniocervical anomalies and hydrocephalus, and it could be seen in congenital causes as well. In this patient with Arnold Chiari malformation, we can appreciate Coming to upbeat nystagmus is purely vertical conjugate nystagmus. It manifests itself in primary gaze and with a slow downward drift of the eyes with a corrective fast upward saccade. So it is present in primary position as well as we had seen in downbeat nystagmus. It might not be present in primary position, and it is usually increases on looking up. With the slow phase can have a variable waveform, which could be increasing, linear, or decreasing. And it is poorly suppressed by visual fixation of a target. And convergence again can have variable effect on it. It can increase, suppress, or convert it to a downbeat nystagmus. And it is usually associated with abnormal vertical, vestibular, and smooth pursuit responses and saccadic intrusions that can produce a bow tie-like nystagmus. So when there is an upbeat and when it comes down, it can have a variable waveform, and in consequently it can appear like a bow tie as well as shown in this picture. So coming to the pathophysiology behind upbeat nystagmus, as opposed to downbeat nystagmus, it is not very localizing in case of upbeat nystagmus. A lesion anywhere from a lesion anywhere from midbrain to medulla can cause upbeat nystagmus. So in this first image, there is a lesion in the ventral tegmental tract, which I had mentioned earlier, which is a tract from pons, which is originating from the superior vestibular nucleus from pons and goes up till midbrain. And when there is a lesion in the ventral tegmental tract, there is reduced excitation of the superior rectus, and that will cause the eye to abnormally drift downwards, and there is a corrective saccade abnormally upwards. That will cause an upbeat nystagmus. In the second pathophysiology, there is a lesion in the caudal medulla, which was originally sending an inhibitory loop to flocculus, and in turn was inhibiting the superior vestibular nucleus. Such an inhibition is lost, and that will ultimately reduce the excitation of the superior rectus, and that will cause a abnormal downward drift of the eyes and saccadic upward saccade. Then mentioned other causes of upbeat nystagmus, of which the most important ones are cerebellar degeneration again, and multiple sclerosis, as well as infarct of the medulla or cerebellum and superior cerebellar peduncle, and posterior fossa tumors, and congenital causes are also common. In this 71-year-old man who had presented with acute dizziness and right-sided paresthesia, can see that there is a upbeat nystagmus with a torsional component. And that was there in primary position and now in left gaze as well as in right gaze. The torsional component is also prominent. In this patient, there was again an acute infarct in the left medial medullary region. There was a left medial medullary infarct. Coming to pure torsional nystagmus, another type of central vestibular nystagmus, the eyes with, in this case, there is eyes with torsional nystagmus have fast intorsion or extorsion that is usually conjugate and symmetric. So in torsional jerk nystagmus, present with eye close to central position, and slow phases can have again a linear increasing or decreasing velocity waveforms, and these are poorly suppressed by visual fixation and are exacerbated by changes in head position or vigorous head shaking. However, as opposed to downbeat and upbeat, they can be suppressed by convergence and often occur in association with ocular tilt reaction as well as in unilateral INO, and can be precipitated or modulated by vertical smooth pursuit movements as well. So in this example, in primary position, There was a now in there is a torsional cyclotorsion towards the left side. If you can see closely, if you can observe the conjunctival vessels, there is a cyclotorsion towards the left side, like in here or here. Only in the right eye, we can see that there is a intorting torsional nystagmus. And in the left side as well, there is an extorsion. Observe the conjunctival vessels. Yes, ma'am. Yes, ma'am. No, still beating towards the left ear. In primary position, the torsion is beating towards the left ear, as we can see. It is towards the left ear in both eyes. And in right eye, it is beating towards the left ear, and in left eye as well, it is beating towards the left ear. Torsion is, from our perspective, it is clockwise. So this left eye on looking towards the right side is beating towards the right ear, and on looking towards the left ear, it was beating towards the left ear. There was a change in direction. It, um, there is a change in direction. That is called it was mentioned as pure torsional disturbance. We are not mentioning the direction. So pure torsional nystagmus is commonly caused by medullary lesions. And usually what happens is when there is a semicircular canal pathway on one side in MLF is affected, that will cause a torsional rift due to intact side. So the intact side is overactive, and that will again cause a corrective torsional fast phase. And the common lesions are usually in medulla, as well as lesions in midbrain like RIMLF, as well as interstitial nucleus of Cajal is affected as well. Yes. Yes. Patient had, in this example with the upbeat nystagmus, and when the patient is looking towards the left, patient has a torsional component towards the left ear, towards the right. And on looking towards the right side as well, the torsional component is towards the left ear. In this case of left medullary infarct. So the common causes of pure torsional nystagmus is syringobulbia, brainstem stroke, AV malformation in the brainstem or middle cerebellar peduncle, brainstem tumors, multiple sclerosis, uh, and oculopalatal tremor as well can cause pure torsional nystagmus, along with head trauma and congenital causes. Coming to the second mechanism by which nystagmus is caused is involvement of oculomotor neural integrator, which dysfunction. So the important subtypes are gaze-evoked nystagmus, rebound nystagmus, endpoint nystagmus, and acquired pendular nystagmus, of which endpoint nystagmus is a physiological nystagmus. So neural integrator is the mechanism by which we can maintain our eyes in eccentric position. And usually in eccentric position, the viscoelastic forces of the eye will force the eye to move towards the primary position, which has the least viscoelastic forces on it. And it is the mechanism by which neural integrators can integrate the eye velocity command, which is given by various other ocular motor nuclei, to produce a position command and keep the eye at that eccentric position. So it allows to hold a steady eccentric gaze and not allow the eye to drift back to the center, which has the least amount of viscoelastic forces. So the neural integrators that are present for horizontal movements are nucleus prepositus hypoglossi and medial vestibular nuclei. And for vertical movements are interstitial nucleus of Cajal. So they convert a pulse of neuronal discharge to a position command, that is the position at which the eye should be kept. And it can, as we age, it can be inherently be leaky, and these are called leaky neural integrators that will cause a slow drift towards the primary position. To counteract that, there are compensatory cerebellar loop involving the flocculus and paraflocculus that will correct such a leaky neural integrator slow drift towards the primary position. So in this picture, we can see the INC, which is located in the midbrain, and NPH, that is nucleus prepositus hypoglossi, is located in the medulla. So coming to the first type, that is gaze-evoked nystagmus. And gaze-evoked nystagmus has jerk waveform movement that occurs in lateral or up gaze. And after each eccentric gaze, the eyes tend to move toward the primary position, and it is followed by a saccade towards the eccentric direction. As in this video, towards the right gaze, in the primary position, there was no nystagmus, and towards the left, there is a left beating nystagmus. Again, in the primary position, there is no nystagmus, and towards the right, there is a right beating nystagmus. So, as in this video, it is induced by an eccentric position, and the fast phase is always in the direction of the gaze, with the slow phase velocity exponentially decreasing. That will be shown in the velocity waveforms. So the defect is in the cerebellar feedback loop, which supposedly prevents such a drift of the eye towards the primary gaze position because of a leaky neural integrators. So when there is reduced cerebellar feedback, that the eyes are allowed to go back to the primary position, that is drift back to the primary position, and a fast beat is saccade is towards the gaze. And it is usually bilateral and changing in direction with amplitude larger on the ipsilateral gaze. Coming to rebound nystagmus. Rebound nystagmus is again a variant of a gaze-evoked nystagmus. And when the subject is resuming primary gaze after a period of eccentric gaze, the eyes drift back towards the prior eccentric, and the eyes tend to drift back towards the prior eccentric gaze with saccade back to the primary gaze, as in this video. When the eye is moving to the left, there is a left beating nystagmus. And the eye is brought to the center primary position, there is a right beating nystagmus. That is the In reborn nystagmus, there is a tendency of the eye to go back to the eccentric position abnormally, and the succade is compensating for that by beating towards the opposite side. In that case, to the opposite side of the previous eccentric position. And this nystagmus usually is transient and usually lasts for less than 30 seconds. And reborn nystagmus is often associated with cerebellar disease, such as those associated with gaze-work nystagmus. In this case, reborn nystagmus is often associated with cerebellar disease as those associated with gaze-work nystagmus. Coming to endpoint nystagmus, which is a physiological nystagmus. It is of low amplitude, less than 2 degrees, and it is usually occurring at maximal eccentric gaze, that is more than 40 degrees of eccentric gaze. And it is a normal variation in gaze holding ability, and it is similar to gaze evoked nystagmus. In the primary position, there was no nystagmus, and when the eyes are turned towards the right gaze, there is transient, only one beat was apparent in this video. There was no nystagmus in the primary gaze, and towards the right, there was one beat that was beating towards the right. It was of low amplitude. And in the extreme gaze, there is a low amplitude right beating nystagmus, and that has stopped after about 3 beats, which is a normal variation in gaze holding ability, which is again present in extreme gaze towards the right. Coming to the fourth type, that is acquired pendular nystagmus. Most commonly, pendular nystagmus is seen congenitally. However, we are interested in the acquired pendular nystagmus, which can have horizontal, vertical, and torsional components, and can have complicated waveforms as well, because of which. And the amplitude and phase relationship determines the trajectory of this nystagmus in each eye, and can have a phase shift between each eye. That is, one eye can have a different trajectory and the other eye can have a completely different trajectory as well. When there is a phase shift of up to 180 degrees, the nystagmus can appear like a convergent divergent type of nystagmus, which I'll be coming to later. So amplitudes often can differ, and so it might appear monocular, and trajectories can be conjugate as well. That is, often can appear similar, but most often are dissimilar. So oscillations are sometimes suppressed momentarily in cases of saccades. Rapid eye movement can suppress acquired pendular nystagmus. The pathophysiology behind this is usually the neural integrators here requires feedback from cerebellum as well as vision for functioning in a normal way. We already know that the neural integrators can be inherently leaky. So it is difficult for us to, in case of pathology, to maintain the position in eccentric position that will cause a gaze evoked nystagmus. However, in case of uh, feedback being excessive, as in case of this, there is excessive compensatory feedback to neural integrators from this feedback loop, and that will cause holding the eyes in the eccentric position in the primary position difficult. That is because of excessive compensatory feedback. The eyes will be shifted to eccentric gaze much more than to be kept in the primary position, and that is the reason for the pendular nystagmus. So this integrated signal activity eventually decays, and that will cause the pendular nystagmus to change in direction as well. With this look, we can explain both the pendular nature as well as the change in direction of the compensatory saccade. In blinks and saccade can actually transiently reset this loop and can reset the pendular nature of the nystagmus as well. So gaze evoked nystagmus is because of leaky neural integrators and difficulty in holding the eye in eccentric position. And whereas in this case, there is excessive compensatory feedback to neural integrators, and there is difficulty holding eyes in the primary position. It will always overshoot and go to the other side. This is usually seen in demyelinating, acquired pendular nystagmus is usually seen in demyelinating diseases, where there is another that is put forward. Usually in demyelinating diseases, there will be affliction of visual input from affected eye, and that will also in this feedback loop. Visual feedback is also important. That will also disturb the visual feedback, and that can cause apparently acquired pendular nystagmus. This is based on the observation that the nystagmus is much more in amplitude in the affected eye of the demyelinating diseases. However, there are certain other observations that negated this theory, as in the nystagmus persisted even if you took out the visual afferent input, that is, nystagmus persisted even in dark. And there is when experimentally this visual input was delayed, there is a different frequency that was observed as opposed to the pathological acquired pendular nystagmus frequency of oscillations that was noticed. So there must be another mechanism for which in demyelinating diseases there is acquired pendular nystagmus. This is an example of acquired pendular nystagmus, where we can see in primary position as well, there are no jerk movements, only slow pendular movements are observable, and they are beating horizontally to either side. I'm unable to play the video again. There is no jerk phase in pendular nystagmus. Or both the phases will be slow in pendular nystagmus. Horizontally in this image. Play out. So both the phases are slow here, and it is nearly horizontal, as in on close the eyes. It is up mental anesthesia.